All right, welcome everyone to the MERZ Aesthetic Symposium session. Today we have a very, very interesting session about skin longevity code, mastering regenerative aesthetic with precision. And I have my dear friend with me, my dear sister, Dr. Kadarni from Australia. She's a plastic surgeon who has extensive experience in regenerative aesthetic. She will start with her first talk. Her first talk on the why skin longevity, a new quest for skin health span. And then the second lecture, she also will talking about the calcium hydroxide for dermal extracellular matrix remodeling, a key precision in regenerative strategy. And then I will be, after her, talking about longevity from the foundation layer in combination consideration for precision treatment. And then after that, we will have the panel discussion. Yes? Great. Are you ready?
I'm ready.
Okay.
Okay, that's me. So, there's a lot of feedback there.
That's okay.
Why skin longevity? This is what we're talking about. Obviously, thank you to MERZ. I'm one of their speakers, and for inviting me over to beautiful Bangkok and Thailand. What have we been doing over the last 20 years? We have been treating the visible signs of aging, right? We've been addressing hollowing, contouring that gets worse as we age and we start to sag, and we've been dealing with wrinkles. But in honesty, what are we doing? We're papering over the cracks. We're not really dealing with the underlying issue, which is tissue health. Now, if we look back, before we had toxins and before we had fillers, it was just in those early days. This was the editor of Vogue. What all beautiful women today have in common is an obvious look of health. Even a model's skin tone implies she leads a healthy life. This is the look today's women try to achieve. So that was the editor of Vogue US back in the late 80s, linking beauty with health and vitality. Then we got toxins and we got fillers and we got EBDs, and we sort of lost our way. We've been treating and looking at sort of hiding it and just disguising it, but we haven't actually been addressing the underlying issues until now. And why now? This is because medicine has really shifted from a lifespan to health span. So we're looking now at not so much as how long we can live, but how well we live. So we don't want our last 10 years to be dribbling and incontinent in a nursing home. We want to be out walking and enjoying life till the very end. That's a healthy life. That's health span. Patients are onto this now. They are seeking prevention, resilience, and vitality. And skin, what we are dealing with, is one of the most visible and measurable manifestations of aging. We know that. Skin longevity bridges aesthetics, regeneration, and longevity science. The skin we have to now regard as more than just a covering organ. It is an organ. It's a physiological organ. It's a huge organ, in fact. It acts as an immune, vascular, neurological, and endocrine interface. Sure, it reflects systemic aging processes in real time. So really, it's a biomarker. It's an accessible biomarker for what's undergoing systemically. So we have to change our mindset. Now, we all know the drivers of skin aging. We have intrinsic, And we have extrinsic stressors such as UV, pollution, and lifestyle. And we have this concept in inflammation. We know that inflammatory, low-grade inflammation is a big driver of this. Mitochondrial dysfunction is very important. We see extracellular matrix degradation and impaired repair signaling. This is what's happening at a biological level, at a cellular level. And then we have hormonal and metabolic dysregulation we have to address. Aging is not linear. Individuals age differently across life stages. Women often experience accelerated aging during menopause. There's variation in phenotypes between patients. And if we think about it as a curve, then early intervention can flatten this curve. So when we look at this trajectory of aging, and skin aging especially, you can see at the top is what is the normal if we don't intervene. But what we want to do is we want to set a patient who is up on the top curve down towards the bottom curve. And you can see it is much easier to get them onto the bottom curve if we intervene earlier than if we intervene later. But even so, this trajectory is not about a moment in time, just a quick, let's do something now. It's about looking at the long term, how we can keep them and keep depressing and keep them on that lower curve, flattening this trajectory. So we have genes. We all are born with genes. It's like a recipe book, all right? You can open the recipe book and have a look, but it's the epigenome that translates it into actually a dish that we can eat. So the epigenome is very important. This is what switches genes on and off, and this is what we can alter. So we need to look holistically at our patients. We try and optimize them systemically. We can consider the long-term journey, all right? So it's not a short, quick switch. It's a long-term issue that we need to think about to reset this trajectory of aging process. Our goal in aesthetics is to improve tissue health while achieving our aesthetic goals. And we need to treat that skin now as a physiological organ. So we need really to understand the science, the metabolism, and treat them medically. Integrative aesthetics is a framework that combines local and systemic interventions. So locally, we look at the tissue architecture, mechanobiology, and regenerative therapies. And systemically, then, at the same time, we're looking at inflammation, hormones, metabolism, what's going on with the mitochondria, what's going on with the microbiome. And we need to think also about what's appropriate at that patient's life stage. Like if they're menopausal, it's going to be totally different than what we do when they're younger. So in the systemic factors, of course, we have genetic and epigenetic factors, and these establish the baseline capacity for repair. Regulatory systems, so metabolic, endocrine, circadian control, they shape the environment for repair. And the immune functions, such as the microbiome and nutrition support, they support recovery and repair processes. So we have non-modifiable factors, genetic, obviously, we can't change that. Well, we can, but we don't normally in practice. Early childhood events that have happened way in the past, we can't change that. But there are a lot of modifiable factors that we need to look at. So obviously, environmental and lifestyle. Those are things we can address with our patients. So together, these factors define the aging trajectory and consequently, underlying skin and tissue health, which is our ultimate goal now. Traditional aesthetic treatments are episodic correction and really papering the cracks. Whereas skin longevity is about preservation of tissue function and the regenerative viability. Our goal is shifting from point-in-time restoration to a long-term trajectory modification. We need to focus on resilience, adaptability, and maintenance of tissue health. So what's in the future for us now? Well, we need to turn more and more to preventative strategies for aesthetics, We need to understand regenerative medicine so we can restore health to our tissues. Biomarker-driven interventions, so what's appropriate for that individual patient. Trajectory modification rather than just corrections. And the skin is a scalable platform for longevity medicine. How do we marry achieving these aesthetic goals with improving tissue health and ultimately longevity? Well, we can consider the tissues as an ecosystem. If you look at the skin, as a surgeon especially, we've always think in individual layers and how we address that individual layers. But it's all one thing. And connecting them right from the periosteum right up to the dermis is this soft tissue system, this fibrous system. So we have the oblique retinacular ligaments deep, dividing up the deep fat pockets, coming into layer 3, this so-called SMAS, continuing up through the retinacular cutis ligaments to the dermis. What we do down here has an effect up here. They're continuous. And then we have an ultrastructural ecosystem. When we look down on our microscope from a cell's point of view, and we have the extracellular matrix, which is fibrous made of collagen and elastic fibers. There are biocues, which are messages that are coming from other cells, from hormones, from other sources, and also released from the extracellular matrix itself. And of course, we have the cells. Now, the key thing to this is that extracellular matrix is dynamic. It's moving. It's not solid like in a textbook. It is not rigid. It is moving. Even in bone, it has a little bit of tension, a little bit of movement. The cells are attached through integrins onto the collagens, click onto that extracellular matrix fibers, and they pick up those tensions and movement. And that upregulates the nucleus. And that's where the connection lies, and it's important to understand that. And I'm going to come on to that in a little bit in the future, but we are in this for the long run now, of improving the trajectory of aging for our patients. Every intervention we do must have tissue health at the forefront. So our strategies, both systemically and local in the tissues, need to minimize inflammation because we know that's one of the significant drivers of aging in our tissues. We need to focus on tissue repair and health. And I think this is where Radiesse has a differential because it follows non-inflammatory pathways. Thank you. Do you want me to carry straight on? So can we load my next lecture, please? Nothing's happening. Oh, well, while we're waiting for the computer, you know what that's like. Has anybody got any questions? Oh, here we go. Now, can we go on to my lecture? Here we go. It's there. All right. So now I'm going to talk about, specifically, obviously it's a MERZ Symposium, about where Radiesse fits in, about where it is important in extracellular matrix remodeling. Remember I said to you about the ecosystem of that fibrous connection through, right from deep to superficial. Coming off that, of course, is the extracellular matrix. Now, we have all these fine filaments that we can see with our naked eye. But when we deep dive down, we have this fibrous structure throughout all the tissues, the extracellular matrix. And it is the tensions that are important, so important. So this is a dynamic system that supports the cells within it. To be functional, an extracellular matrix has to be dynamic, it has to be moving, it has to have the tensions, one, to match the structural requirements of that particular tissue. Obviously, bone has to be strong and rigid, whereas fat is fluid and soft. Dermis, of course, is quite elastic, stretches out and pings back. So each has its own tensions and flexibility, and to be functional, it has to be specific for that cell population. So a fibroblast in the dermis is a different beast to the fibroblast that is down in the retinacula, deep down between the deep fat pockets. They each respond to different tensions, and even more so when you talk about periosteum, because this structure, this extracellular matrix, is what the cells attached to. And if we're going to have a healthy, functional extracellular matrix, it has to be very specifically correct to allow attachment of the cells, so the cells will thrive and proliferate. The extracellular matrix also provides direct cues to the cellular population. And of course, it's got to allow diffusion of nutrients. Blood supply has got to come into this tissue. If it's wrong, if that extracellular matrix is too stiff, we get disease. This is scleroderma, and it's a fibrotic disease. The extracellular matrix is too stiff for the cells in there, so they are not happy. So if we drive a stiff extracellular matrix through too much biostimulation or incorrect inflammatory processes, we're going to tend towards this when cells aren't happy. Sure, you produce a lot of collagen, you're going to get volume, right? So again, we're coming back to patching patching over the cracks and the hollows and the irregularities. You're going to get volume, a lot of collagen, a lot of elastin. It's volume. But is it a healthy tissue? This is where I want you to think about, because that's not what we're after now if we're talking about tissue longevity. If we're going to regenerate an extracellular matrix, we need to get all the components. They need to be in the correct ratios. They need to be in the correct three-dimensional architecture so the cells can attach. And the tension and fluidity must be right for that cellular population. It's not easy. If we get it right, we see it clinically. We see improved tissue function, pliability, dermal thickness, reduced pigmentation, healthy tissues, and good fat metabolism. So overall, we will improve the aesthetic appearance of health and vitality, going right back to what the editor of Vogue said back in the 1980s. It's all about health and vitality of the tissues. So how do we go about restoring the extracellular matrix? Now, Atuma, have you any idea, because that clock is wrong, how long actually?
Yeah. Plus 10 minutes.
So it's 15 minutes to go. Good. So how do we restore a functioning extracellular matrix? Well, obviously, we're going to have to wake up the cells which have regenerative potential. Remember, when we age, our cells from the youthful state are active, they're making stuff, they're going for it. We can get senescent cells, which I call the cells with Alzheimer's disease. They refuse to die, and they're quite destructive. But there's another population of cells who are just having a little bit of a nap. They're taking time out, the quiescent cells. They're our target. We want to get them to respond in regenerative pathways. We don't want them to just go hell for leather and produce bucket loads of collagen and proteins that are going to fill up the divots. We actually want them to go gently and regenerate the tissues, because we're aiming now to rebuild natural structure and physiological function. So these are our targets: fibroblasts and stem cells. As a surgeon, and it's still happening, you'll see it a lot in this conference, we are putting stem cells in. That's always been the stock standards. Putting stem cells in to try and restore health to the tissues, replace those cells. And we now know that we used to think that stem cells, well, they are theoretically pluripotent, which means they can change their phenotype into the local tissues, but they usually don't do that. All they do is embed and produce an ongoing source of anti-inflammatory cues. So they're very good continuation source of biocues, but they rarely actually differentiate these days. PRF, PRP, that's a moment in time. That's a collection of biocues, but It's just they work and then they're gone. It's not a sort of ongoing source. Exosomes, off the shelf, again, point in time. Problem with exosomes, we don't even know what's in half of them, and it's very unregulated. Peptides, to me, peptides are nuts. I don't get why we're using peptides, because this system, immunological system, is full of positive, negative feedback loops to be very, very, very finely controlled. Unless we know from biomarkers that there is one or two elements that are missing, just throwing in one peptide can throw the whole system off balance. And hello, we are seeing problems, aren't we? With lumps and problems and inflammatory problems, because you're throwing that finely tuned immunology out of whack. So peptides, I think we've got a long way to go before we sort that out. Stem cells. Young stem cells in healthy matrix, great, you're going to wake up your fibroblasts. However, we're talking about aged, fragmented, stiff extracellular matrix. And the stem cells struggle with that. They're not as responsive. And even more, if you're putting autologous stem cells in, you've got aged stem cells who are not functioning well in an aged matrix. It's not an ideal situation. So what is our alternatives? Because to me, the more I read, the more I study, the more I do research, I am aware that extracellular matrix is the key to all this. And this is me coming from surgery where we used fat transfers all the time. We need a healthy matrix. So how the hell are we going to get this started? Because we want to get collagens in the correct ratios and architecture, elastin in the correct architecture, ground matrix components, a vascular network. And so this is where a regenerative scaffold comes in. Remember I said cells attach to the extracellular matrix. This is a very fast responding system. It's much, much quicker and more efficient than biocues, which act on a cell receptor, cell membrane. This is a very fast system. The cells attach, they respond to that movement, and that transmits through the cytoskeleton up to the nucleus, and that regulates those genes. We have three, when we talk about regenerative aesthetics, we have three pillars. The cells, which are briefly covered, biocues are briefly covered, and biostimulatory scaffolds. So what is a scaffold? And I often hear, oh, how the hell is Radiesse a scaffold? Let me explain. A scaffold, when we talk about biomaterials, and we're talking about orthopedics, cardiac, whatever, biomaterials, it's a three-dimensional matrix that mimics the biophysical cues of the extracellular matrix. It provides physical and biochemical cues which stimulate the cells to thrive and proliferate. It's very specific to the cells within that tissue. As I've said to you, these cells are incredibly fussy. A fibroblast in dermis does not like so much a fat extracellular matrix. It wants its own extracellular matrix tensions and biophysical cues. So in essence, what we're trying to do is con our cells with a foreign material into thinking they might be in something that's they can live with. I mean, it's not the perfect world. We're trying to get there in biomaterial world, but they still want something that cells will look at and go, you're familiar, click, click, and hang on to it, all right? That is a scaffold. And calcium hydroxyapatite microspheres act as a scaffold. We know that bottom right-hand picture is a fibroblast in the lab hitching on to a calcium hydroxyapatite microsphere. It's a ceramic material, it's ionic, it's crystalline, so structurally it's got physical elements and the cells sort of recognize it. Also, calcium hydroxyapatite is a crystal or a chemically similar to something we have in our body, so that we don't reject it outright, and these cells will actually attach to it. And you can see that bobbing around, that is calcium hydroxyapatites with fibroblasts pulling them around the Petri dish as they're attached to them. Biostimulators. most people think, and it comes from the days when we used to use, and we still do, use calcium hydroxyapatite to drive volume, autologous volume. All right? So it was, all the biostimulators were originally designed to drive collagen, elastin, just fill in the hole, right? It was volume. That's all we wanted out of it. But we have realized, and we know from biomaterial world, there is a difference. The basic difference is, as we're talking biomaterials, there are 3 classes of biomaterials: metals, ceramics, and polymers. Well, we don't inject metals in the face, but we do inject polymers and ceramics. And the only ceramic we're injecting at the moment is calcium hydroxyapatite. Polymers are automatically, your body rejects it. Well, they don't reject it, but they just don't like it being there. Our immune system will see it as, you're not meant to be here, and the mechanism of action is it drives this response to seal it off, to enclose it, so that it produces, gets those fibroblasts going hell for leather, producing lots and lots of collagen and other proteins as well. But it's not about putting it together into architecture and recreating an extracellular matrix. It's just pushing out a whole load of volume. Radiesse used to be thought of that way too. It still will produce a lot of collagen. But we now know through a lot of data, and we're looking back, and some of it's quite historical, that if you dilute it especially, it will become more regenerative. It's different because it's ceramic, it's an ionic. And if we go to biomaterial science, we really understand that. So very simply, we did a study to show that a ceramic injectable, CAHA, versus a polymer injectable, and we used PLLA, that the macrophages, which are the inflammatory cell, they're the number 1 cell that controls the response, that they behave differently. And when we put the macrophages in with these 2 products, they behave very differently. When you put them in with CAHA, the ceramic, they didn't put out any inflammatory cytokines. Yet when we put them in with a polymer, they produced inflammatory cytokines, which makes sense. That's how they work. And if you want to know more about that very boring immunology, it's in this paper here. So going back to now, thinking about yes, we want volume, yes, we want those aesthetic improvements, but we want healthy tissue. If we upregulate and we get our stem cells working in a healthy matrix and get our fibroblasts waking up, it's all fine and dandy. But if we have inflammatory process or we overstimulate, this is the situation we're going to get to. We're going to get a dense, stiff extracellular matrix, and the cells are just not happy. They're not responding. They want that movement. They're not getting those messages, and they're not going to behave optimally. This is the issue. We need to get a healthy extracellular matrix. All biostimulators will pump out collagen, elastin, proteoglycan, whatever. But we have to get it from that blob of protein into something that works, that's a lattice. And that is the remodeling phase. So we can, when we look, and this is all related to the tissue repair pathways, when we go from a proliferative phase, which is where we get all that outpouring of proteins, that's a provisional matrix. It needs to be remodeled to get to a mature extracellular matrix. And this is something that I and 2 colleagues of mine, Katie Goldie and Gabriella Casabona, have been studying for the last few years. And at last, we got our first paper published only a couple of weeks ago. So the study we did, we injected various biomaterials into an abdominoplasty patient and biopsied it at 6 months, 3 months, and 14 days out, just to look what was happening. Are we seeing remodeling? We saw upregulation of the genes, but as I said before, that's just like opening the recipe book. What we need to see is actually what's happening. And we were able to see, and this is just brief snapshots, we were able to see evidence of that remodeling with collagen. We got a spike at 3 months, the provisional matrix, and then by 6 months it's dropping back, which you want to see if you are seeing that remodeling. More so in the diluted Radiesse 1-to-1. Decorin, which is a little proteoglycans, which is very important to the fibrillogenesis. It also is important in regulating extracellular matrix deposition. That followed suit. More in actually the dilute radius, 1 to 1, 1 to 2. Elastin. Elastin is a protein. We saw that as part of the extracellular matrix, provisional matrix. And then fibrillin 5, which is important in putting those elastin proteins together into elastic fibers. That was coming in at 6 months, when we are seeing now that remodeling into a structural matrix. Versican and other proteoglycans, very important in fibrillogenesis. That followed suit in that provisional matrix. It spiked and then dropped back. Senescent cells. Senescent cells, as I said, are the cells in Alzheimer's, when in fact, they're very important in that remodeling process. Along with MMPs, they break down that provisional matrix, all that bunch of protein, break it down so that we can rebuild it into something that's structurally and architecturally correct. We see it on histology. If you look here, this is Cahal 1-to-1, which we clinically also recognize as probably the most regenerative dilution. 1-to-1 at 14 days, you can see that dense. You see those pink river of collagen on the left. 3 months, we're seeing the microsphere starting to break down, starting to crumble a little bit, but you still see a whole heap of collagen and other proteins in there. And then by 6 months, we're seeing this lovely open basket weave. That is more what you want to see in a healthy histology, not just rivers of collagen, which is more fibrotic. Clinically, this also we were able to demonstrate on the same patients. Gabby Casabona took her ultrasound out and was able to show an improvement in elastosis. So that sort of ultrasound lucent area between epidermis and dermis, she was able, which is indicative of solar elastosis, that improved dramatically, mostly in the 1-to-1 ratio. Also, the skin thickness, the dermal thickness improved, mostly in 1-to-1. Now, what is interesting, we were injecting, the royal we, it was actually Gabby injected it, I was just in the lab, but injected it under the skin, subdermally in that subcutaneous fat, and yet we could see an improvement in the dermis and the skin. So what does that tell you? That by improving deep and improving retinacular cutis, we are having a paracrine effect upwards into the dermis. That's why you see it when you inject with your cannula, we see improvement superficially. So we can quite categorically say calcium hydroxyapatite, radius, is a regenerative biostimulator. It provides the physical and biophysical cues to the cells that they need to attach and recognize, and that will upregulate. They don't go straight down an inflammatory foreign body pathway. It avoids that, okay? And that foreign body pathway, PLLA, PCL, great if you want to put it deep and get collagen, and you want to fill in the holes and get volumetric changes. But is that healthy tissue? Is that a healthy extracellular matrix? Is that going to give you tissue longevity? I would argue not. I wouldn't be putting it in me. There is evidence of remodeling that we have shown of the provisional matrix into a mature extracellular matrix. That is what's giving us the healthier tissues. I mean, it's not perfect. In regeneration, we don't have perfection. The only time we get perfect regeneration is intrauterine wound healing. We start to lose it more and more after the baby is born and as time goes on. But we're trying to, every intervention we do, we must try and do it in a healthy, non-inflammatory way and try and get as close as we can towards a healthy matrix. Because ultimately, we are going to see an improvement in tissue function and tissue health. So we are now in this for the long run with improving the trajectory of aging. So every intervention we do must have tissue health at the forefront. We need strategies that minimize inflammation. So I'm sorry, it's as boring as hell, but you have to understand immunology in the tissues if we are driving and putting things in to change them. As I said, you know my position on peptides at this level of our knowledge. Our focus must be on tissue repair and health. Thank you. So I'm now going to hand over to my good friend Achima, who's going to talk to you about how we actually do that.
Okay. Yes.
All right, so while we're waiting for the computer to, does anybody have any questions? Would anybody like to ask anything on that? Or any thoughts, comments? Was it really that boring? Nobody wants to say anything?
I hope I don't bore the audience. I wanted to make
Okay.
ทำให้มันกว้างไม่เห็นทำให้มันกว้างไม่เอา
If you click on that, maybe it'll work.
Yeah. Okay. Yes.
Ah.
All right.
Okay. All right. So, Achima.
Yes. Okay. So, I'm going to be talking on longevity from the foundation layer combination strategy for precise treatment. The question that I would like to ask the audience before I proceed. You see that why do good treatments sometimes fail to last? Do you know the answer? Because a lot of time we're treating the symptom rather than the cause, or we over-align on just one modalities instead of doing combinations, and a lot of time we treat only superficial correction, while the problem is actually deep. Or sometimes we might provide poor sequencing of devices and injectables, and a lot of time we don't really care about tissue biology and not even consider the patient's specific aging pattern, and that why even you do good treatments, it fails. So, and that we've been doing for decades. We're treating the surface, but we don't looking at the whole biology, the whole cell biology. We don't treat the system. So this is the era that we're shifting the idea and the paradigm of our treatment, not just trying to do just temporary corrections or masking just only the superficial defect, or correct what you just only see, or using just single modality. Now we trying to do more of a combination to restore tissue functions. Particularly, we pay attention on the ECM resilient. And we also pay attention on cell biology. We're looking at foundation of biology before doing refinement. Because aging skin isn't just about wrinkle or fold, it is about biological change. And ECM remodeling, ECM dysregulations is considered to be the 13th hallmark of aging. If you look at the age skin, at the cellular aging skin, you see there's accumulation of all the zombie fibroblasts which is sitting there and is not working, and the secretion more of senescent-associated secretory phenotypes that create chronic inflammation that we call inflammaging, and our stem cell is not working and it's not talking to each other. They don't communicate between the cells. So that's why we have decrease in proliferation of fibroblasts. We also have not only the function, but also decrease in the hyaluronic acid, the collagen, elastin synthesis. And also we increase the fibroblast synthesis and also increase in inflammatory aging. So the goal of regenerations or the goal of treatments at this era, we try to targeting over the hallmark aging at the cellular level and focusing on how can we remodel the extracellular matrix, or how can we kind of pampers over the environment of in the intracellular matrix to create a supportive environment to the cell to be able to restore tissue integrity across anatomical layer. So I was, come to idea that there's an outcome, we can get the natural and longevity outcome by looking at the 3 foundation causes of aging. Not only anatomical foundation that we are always looking at, the bone, ligament, fat, fascia, muscles, dermis, and epidermis, but also looking at biological foundations, which is a molecular hallmarks of aging. And also strategic foundations, the correct modality with the correct rate at the correct time, at the correct endpoints, and followed by intelligent maintenance. And be looking at regenerative strategy of how we can remodel the ECM and how can we create stem cell supporting environment to restore a tissue integrity. So when we're looking at biological foundations, we try to looking at how can we master the way we can create regeneration through a precise layer combination treatments. Because when we look at the ECM is not a passive or inert place that held cells together. It's actually very important because ECM will tell the cell fate. It will drive whether the cell will be regenerate or will become fibrosis. So we need a healthy ECM to create a healthy tissue or regenerate the tissue. So basically ECM actively regulate the cells through the mechanotransductions. And we know that when we age, what happens is, instead of having like a nice spindle cells, our cell is kind of round, and we lost the contact, loss of tensions. So we losing the activations. So with the physical force through this tensions, either by the native ECM or either by we putting scaffold, it actually creates tension and will stimulate or trigger biochemical signals, and then it will create the cell growth, migration, or tissue repair or tissue regenerations. So basically, this is what we want it to happen. We want the tissue to be regenerate, not repair like a fibrosis. So we want the tissue to regenerate, to restore a native tissue architecture, not just fibrotic repair. So this is very important that when we look at procedure that we do, we would like to create a healthy ECM to make the repairment finally goes into regenerative pathway instead of creating fibrosis. Now we're looking at anatomical foundations. The true tissue regenerations actually requires, respecting the distinct anatomical plane, which is starting from diagnosis before you do anything. Correct diagnosis is very important. So this has to be pathological anatomy different. We have to understand the aging pathology, and we have to understand the functional anatomy, and we have to treat it accordingly, according to the true cause, primary pathology, primary anatomical problem, not just the end results, what we see. Because if you're looking at what's happening, you have to be able to understand what is anatomical aging changes that turn into aging morphology. And then when we're looking at the patients, we assess the aging morphology, and then we have to translate back what is happening beneath. Okay? And we all know, what happening, we age by layers, so we have to know each layer. When we're treating, we not only treating on the horizontal plane, we also have to looking at the vertical plane, which is SMAS support, which is a retaining ligament support, and the retinacular cutis support. So as I'm mentioning, translate aging morphology into anatomical diagnosis. This is the key. Because when you see the visible sign of morphology of aging, there are actually invisible foundations happening. So we have to be able to translate and treat the true cause before treating the surface. So we have to looking at the what's wrong in the foundation and treat the cause, not just the shadow that you see outside. Because when, for example, like when you see wrinkle may reflect the muscle activity that pulls the dermal aging, mean that your dermis is also deficit. That's why some people have very severe age wrinkle. It's not just about muscle, but it also the dermal component. So you also have to looking at the dermal component, the quality of the skin together with the actions of the muscles. And so not only treating the structural correction, but we also have to looking at the poor skin quality, which also can aggravate the severity of aging. So understanding aging pathology and anatomy very important. And then you choose your toolbox, what you pick in your toolbox to use with the right technique. So pick the right toolbox and then choose the right technique. And importantly, that it has to be individualized, treatment for your patients. Assessment is important. We don't look at the 2D anymore. We have to assess the patients, looking at the true anatomy, including the dynamic problems. Diagnosis had to be both, looking at both in together in both static and in dynamic movement, and looking at all the aging morphology and try to identify which is the dominant aging morphology. Whether it is because of a failure of structural support, or it's because of ECM tissue quality, or it's because of dynamic muscle excess, or volume or contour deficiency, or surface deformities. So all of that has to be comprehensively assessed when you're looking at the patients. It's also, when we look at the clinical signs of aging morphology, it's also nice to be able to understand why it happened. For example, when we look at the patient and skin dull and skin have a repair deficit of a repairing capacity, it could be from a lot of numerous biological hallmarks that will lead to how we're going to treat the patients, not only from trying to just laser the patient, but we also try to improve the skin quality or improve the ECM resilience. So basically, this is the way that we're thinking. We identify dominant aging morphology and then try to looking at what will be the proper aging pathological anatomical layer support, and then matching the treatment that you want to be treated. In the toolbox, your toolbox will be different. You will be different from mine, but there are many ways that you can, use all of these approaches to correct your aging pathology. Looking at the foundation failure. So basically, this is what I treat my patients. So I customize techniques of treating my patient by assess over the lower face up to the upper face. But when I treat patient, I treat from upper to lower. And then I treat the lateral part of the face first. I treat deep structure deficit first. So this is the way that I'm thinking. I think that this way is efficient to treat the patients with the natural outcome. So at the lateral face, we know that there is a distinct anatomy of the lateral part of the face, which is this lateral layer. The layers are in parallel and contiguous to each other. So when we extending or when we manipulate the upper part of the lateral face, it will help to pulling up the whole face. So that will actually affecting the whole contour of the face. So the idea that I approach is I would start with the lift and redrape from the lateral part, and then I feel the structural support, the contour and projections, and then I will come up with the treatment for skin quality. So this is basically, as mentioning before, lift a lead forward over the lateral part of the face, and then feel structure support toward the projection, and then going to the skin quality. And there's many ways you can do it. You can do strengthening the lateral part of the face by using many modalities. You can use a thermal smash non-invasive tightening by using the microfocus ultrasounds, or you can use the fillers injection using posterior temporal super smash technique, or you can also use the HAHA injections on this area with spatial technique. You can also help to strengthen in this particular point of the temple, which seem to be a level-edge point to treat the facial lifting efficiently. And also in the mid and the lower part of the lateral face, you can also using the energy-based UI together with the filler products or biostimulators according to pathology of the patients. As mentioning, temple is a control zone. It's actually a strategic point, a strategic zone that can actually release to how can you improve the upper and lower face. So it's control how the mid face and the lower face behave. This could be a very effective structural lever over to contour the facial shape and facial lifting. And the publication that I did in 2018 on this technique is very useful and very safe if you do it correctly, very efficient, and you can use it to improve mid and lower face aging, and it can be very, very effective to avoid the overview appearance. If you do it correctly, you can reposition the soft tissue on the mid face and the lower face efficiently. And then you can, and that particular area, you can also using not just only the fillers or not just only injectable, you can also using the energy-based device. Apply at the same locations. You're just trying to reconditioning the deep support over here at the temple, posterior temple area. You can also get the same result as you doing the filler injections. So basically at this part of the layer of the smash and deep RC and deep RTL and RC strengthening, you can also using the device by using the microfocus ultrasounds together with the injectable. And this is the way that I inject the CAHA into this particular area. It also helps to strengthen the retinacular cutis. That will help to pull up the skin very nicely. And when we looking at the CAHA and this particular area, it's also helping as a liquid implant that help to remodel structures layer here, which is retinacular cutis, retaining ligaments, and smash that create the tensile sting at this particular point. It will help to tightening smash and strengthen the RC and RTL and create a long-term lifting in this area. And besides that, this one, you can also using the HA product, bilateral product in this area. It can also help to create very nice lifting. You can also inject posterior temporal fossa together with the anterior temporal fossa to create the complete improvement of the mid face, the lower face, including the lateral eyebrow drooping, and also connection to the forehead and temple. And also we have to restore a deep structure support. You can also use undiluted calcium oxyapatite or biomimetic hyaluronic acid. In this, where there is a deficit of the bone resorption, and with deep structure plane correction, it will really help to improve, to strengthen the deep foundations where there is a deficit of the bone resorption. And the unique application of the CAHA in this area, it's, there is a publications of periosteal remodeling by using CAHA. It's shown that it's mimic a native bone mineral. It demonstrates that it induces, bone conductivity, and it can activate the periosteal stem cell. Even though we don't have evidence with the radius that it can help to demonstrate these osteoconductive activity, but because in this periosteum there is cell structure with fibroblast-like cells, so we can imply or we can hypothesize that radius of calcium hydroxyapatite R may stimulate these cell preparations. It also maybe can contribute to bone regenerative, process, but these need to be, further studied. And then we're looking at skin quality. My time is up. I will go very quick on this one. When we're looking at the ECM skin quality, as Dr. Kadev that already demonstrated very nicely how radius can help, to stimulate the dermis. It helped the ECM remodeling, and the dilution, the best dilution that I use is 1:1. It's helped to stabilize DHA. It helped to remodel the ECM through the signal pathway. Is not only the physical cues like, the biophysical cue of the scaffold product with the calcium hydroxyapatite particles, but it also has biochemical cues properties that it help to promote the fibroblast migration, induce myofibroblast differentiation, and helps in remodel the ECM efficiently. And it also affects the myofibroblast differentiation and create ECM synthesis. And this is more like a deep science, but it's physically strengthened and stabilized DHA. That's why when you treat melasma patients with CAHA, and then you see that melasma lesions improve in some patients. So these also, with the regenerative effect of the CAHA, it can help as being a scaffold, being, the biocues, and also help in terms of giving improvement in terms of functions of the skin that will create a healthy skin, and then it can help to regenerate your skin. And then it's also help in terms of epidermal, support epidermal barrier functions. It also have effect on keratinocyte, including differentiation of the barrier protein. Because not only the calcium, not only about the scaffold calcium oxyapatite, but radius, when you inject into the skin, is create the calcium reflux. So it supports replenishment of the vital organ of the calcium gradient, which is very important for for skin barrier integrity. So it promotes the epidermal barrier functions. It helps in keratinocyte differentiation. It also helps in barrier protein stimulation. So it not only ECM remodeling, but it also helps to create like healthy epidermis. It creates improved barrier integrity. That's why when we're treating the patients feeling the skin is more healthier, it's more stronger, it has more skin hydrations. It helps to improve the barrier protein. It helps in keratinocyte functions. It also helps in terms of barrier, and you see that it helps in keratinocyte. Patients have improved in terms of skin quality. There's better skin refinement with the radius. And also, when we apply together with the skin quality refinement, we also can use the intradermal, the toxin injections that you can help with the intramuscular toxin injection to reduce the downward pulls of the depressor muscle actions. You also can use the intradermal injections, by doing the pan-facial, multi-level, doing intramuscular together with intradermal to create a skin improvement, creates skin lifting. So this is like, you're doing the whole anatomic layer of treatment already. So we're shifting from just, doing the short-term anti-aging to the longevity of aesthetic restoration and the treatment, focusing on how can we improve the ECM remodeling, and then more target on the ECM dysregulation. The strategy that I put it here is with treating the foundation first, doing, importantly, diagnosis with anatomical pathology before we select what will be the right modality to treat, to treat patients. And with the 4-layer architecture, doing deep lift with the microfocus ultrasounds for non-invasive structural lifting, and using radius as a deep structure foundations, and using dynamic control, using Symposium, and refining skin quality by using both diluted Kahar and also the intradermal Symposium. That will be the whole holistic improvement of the skin rejuvenations. Yes.
Thank you, Achima. Thank you so much for a great talk. I think we're actually going to have to close now because the next session will want to get started. So if you want to ask any questions, we'll have to do it outside. Thank you.
We have